He keeps telling me.
Is it? I have.
Yeah.
Mudit is a HOD now.
Arey, sir.
We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 191, Retina Session 43. And today we have with us Dr. Mudit Tyagi, sir. And he's currently the head of the department at LVPI VR Services. He did his MBBS from KMC Mangalore and continued by MS in BJ Medical College, Ahmedabad. And he finished his fellowship in Retina and Vitreous from LVP. And his main interests have been retinal detachments, macular holes, and uveitis. And he has developed a very innovative surgical technique for retinal detachment and macular hole surgery, and it has even won a place in the as the best surgical innovation of the year 2019 by VRSI. And sir has received several prestigious awards, and he is known for his teaching skills. So over to you, sir. I wouldn't take much of your time.
All right. Yep. Thank you, Rolika, for those kind words. And first of all, thank you so much, Dr. S.H. sir and team iFocus for giving me a chance to talk to all of you about drug toxicities in retina. So are my slides visible?
Yes, sir.
All right. Thank you so much once again. So there's a very interesting saying by Benjamin Franklin: an investment in knowledge pays the best interest. I think for every resident, for every personnel, everyone who is pursuing a career in medicine, I think an investment in taking a good meticulous history, I think there can be nothing which can pay a much more reward than taking a good meticulous clinical history. So careful history and examination actually is half of our work done when we are dealing with any medical disorder. I'm not just talking of ophthalmology, but I'm talking about everything in general when it comes to medicine. And let me just show you one example. This has actually got nothing to do with drug toxicities, but this is one case which brilliantly illustrates how a good history can come to a rescue. So this was a 27-year-old male patient who came to our clinic with these multiple lesions, which you can see on his right eye as well as left eye. And you can see this dendritic extension of these lesions in both the eyes. And an FFA showed leakage over here, and an ICG showed some areas of void areas, and then subsequent again areas of staining. And OCT showed these curvilinear bands over here, which we can see, which basically denote a damage to the outer retinal structures. And everybody initially was perplexed as to what we are dealing with. Initially he was labeled as a case of choroiditis. People had advised him to undergo uveitic investigations, and somebody even started systemic steroids for the patient initially. But a good clinical history when we went back, because it was not fitting into any of our clinical parameters. And that's when we found out that this patient actually was an amateur biker, and he was trying a new laser, and he was trying a laser pointer, and he was flashing it in his own eyes. And that's how he got these laser-induced maculopathy injuries. These are areas of ischemia. Now, I know this has got nothing to do with drugs or drug history, but the reason I wanted you to show this case was to illustrate how a good history can come to our rescue whenever we face any diagnostic conundrum. So just because we took a meticulous history, again, this patient then finally confessed that he was using a laser pointer, and then the history of using laser pointer, these multiple dendritic lesions, basically helped us in nailing the diagnosis of this being a case of a laser-induced maculopathy. So coming back to careful history and examination, why is a drug history important for all of us? Two things. Number one, anaphylaxis. If you have a patient who has got a history of past anaphylaxis to any agent and you don't elicit that history, you will end up in a soup. A patient who has a history of allergy to penicillin, and if you give them penicillin, it can be as good as passing a death sentence for them. Similarly, patients who have got a history of anaphylaxis or a history of allergy to sulfa derivatives, if those patients come to you with high IOP, Diamox, again, one of the most commonly used drugs, becomes contraindicated for us because it's a sulfa derivative. So knowing a past history of any drug allergy becomes important. And second reason for taking a good meticulous history is something which we will now discuss in the rest of the discussion about the adverse effects of drugs and how a lot of drugs can have adverse effects on retina. So let me show you a few illustrative cases of how drugs can have an effect on the eye, on ocular inflammation as well as retina, and how history and a drug history helps us. So this was a lady who presented to us was initially diagnosed as a case of bilateral angle closure, was started with AGM, pilocarpine, Diamox or acetazolamide, and was advised for a YAG PI locally. When she came to us, her vision was PL plus and PR inaccurate in both eyes. The AC was flat. You can see the circumciliary congestion, DM folds, and a dense fibrinous reaction with no view of pupil or any iris details. And this is what we can see. We can see underlying stromal edema over here. A B scan showed presence of choroidal detachments, which we can see over here in both the eyes. So peripheral CDs, corneal edema, flat AC, that was how the patient presented to us. And when we took a history, again, this patient gave us a history that she had suffered a road traffic accident, had a hemorrhagic contusion, but was also taking treatment for bipolar disorders. And for that, she was given topiramate. Now, topiramate is known to cause angle closure as well as corneal congestion and choroidal detachments. So there are reports of topiramate-induced uveitis and angle closure glaucoma and hypopyon uveitis. And pen uveitis is known to be a side effect of topiramate. So this was basically a drug-induced choroidal effusion and anterior uveitis. This patient was asked to stop topiramate, and we started the patient on topical steroids and cycloplegics. And within 3 days, the edema started regressing. Visual acuity improved from 3L plus to 20/60, 2200, and CDs also started regressing. UVM again showed a regression of CDs, which was there. So we continued the patient on topical and systemic steroids and atropine. And in 1 week, the visual acuity improved to 20/50 in one eye and 23/20 in the other eye. So you can see this contracting fibrinous membranes with no sign of active inflammation in both the eyes within 1 week. And that is how the patient miraculously responded when we discontinued topiramate for this patient. So again, in a week, most of the CDs have regressed. And in summary, this was how the eye was at presentation. And subsequently, 1 week of topiramate discontinuation, this is what we see. Peripheral CDs on B scan, again regress within 1 week of discontinuation. So again, a drug history becomes important because we were able to nail it to topiramate, discontinue the drug, and that helped us in biding over the crisis. This is another case. So the patient referred to us from Lucknow actually. Patient came with hypopyon uveitis in both eyes, intumescent cataract. Somebody had actually attempted a PI over here to take care of the angle closure. But when we took the history, again, we found that this was a lady who was using topiramate for her depression. We stopped topiramate and started the patient like the previous one on steroids and cycloplegics. And within a week, you can see a dramatic improvement of the hypopyon regressing away, the angles becoming more deeper, and the cornea becoming clearer. The peripheral CDs which were there, again regressed. So if you see a patient who has got angle closure, sudden angle closure, corneal edema, signs of peripheral choroidal detachments, think of these drugs and take a good history. So the treatment for that is discontinue topiramate, IOP control. The iris lens diaphragm which shifts forward needs to be taken care by the cycloplegics, and inflammation needs to be controlled by steroids. Remember, there is no role of myotics, peripheral idectomy or Diamox in these cases. So this is another case. This was a case who presented to us again with extensive inflammation, vitreous opacities, membrane over the iris, membrane over the anterior chamber over here. This was a patient who had initially presented to their primary ophthalmologist with bilateral angle closure. Somebody attempted doing a cataract surgery along with a trab. And this was the disastrous result of what happened over there. Unfortunately, if they had taken a good history, they would have found out that this was the patient who had used chlorothalidone a week back. And this was basically a sequel of chlorothalidone-induced inflammation. All that this patient needed was discontinuing chlorothalidone, starting steroids and cycloplegics, and we would not have ended up in the soup which we were here. Subsequently, this patient underwent this membranectomy, had to remove all of these membranes, remove ciliary body membranes, put oil inside the eye. Patient did end up getting a vision of 20, 100, 21, 25 in both the eyes. But the point is that all of this would not have been needed if we had taken the history of what are the drugs the patient was taking. So agents like topiramate, hydrochlorothiazide, trimethoprim, even sulfamethoxazole, Bactrim DS, acetazolamide, all of them have been known to cause occasional episodes of panuveitis, choroidal detachments, ciliary body effusions. And whenever you see such a patient who presents with a sudden onset of such symptoms, it becomes important to take a step back, pause, and take a good drug history. So this is another case. This was a patient who presented with a sudden hypopyon uveitis, and the patient was on treatment for tuberculosis. Now again, Someone may probably think of this having an active inflammation and uveitis which is flaring up. But the point is, this was a patient of multi-drug resistant tuberculosis, had been started on rifabutin by their primary pulmonologist. And rifabutin is known to cause a hypopyon uveitis. It's a dose-dependent side effect which happens on doses over 300 milligram. The condition may be asymmetrical with hypopyon in one eye and uveitis in the other eye. And sometimes these hypopyons just resolve on cessation of rifabutin. Again, a point which shows how important it is to take a good history. So multiple drugs have been known to cause ocular inflammation, including rifabutin, sulfonamides, bisphosphonates, corticosteroids, even intracameral antibiotics, and we'll come to some of them later on. Apart from that, there can be multiple areas or multiple structures in retina which can get affected by various drugs. You can have toxicity at the level of RPE and photoreceptor. You can have signs of occlusive retinopathy. You can have damage to ganglion cell and optic nerve toxicities, and you can have other manifestations which we shall just deal with. So one of the most common drug causing an abnormality or a damage to the RP photoreceptor complex is chloroquine. So a lot of times you will see or come across patients who have been given hydroxychloroquine or chloroquine derivatives for a lot of connective tissue disorders, including SLE and other disorders. And it's a very commonly used drug in rheumatologic circles. The point is that long-term use of chloroquine leads to degeneration of RP and neurosensory retina. And daily doses exceeding 250 milligram with a total cumulative dose between 100 to 300 grams can lead to development of features of toxicity. One of the earliest signs which you may detect is either a paracentral scotoma, followed by macular pigment stippling and a bullseye maculopathy. But earlier to that comes the OCT features, which we'll just go on and see in the next few slides. So this was one patient who was on hydroxychloroquine for 7 years for SLE. And when she presented to us, she had got this classic bullseye maculopathy in both the eyes. And autofluorescence may even more be helpful in identifying these areas of damage over here. And a parafoveal increased autofluorescence signal is detected in early stages. So you do not even have to wait for development of a classic bullseye maculopathy. And early autofluorescence in itself will reveal these signs. So patients who are on SCQ for a long duration need to be screened and need to be seen to rule out these RP damages. On OCT, what you will see is a loss of parafoveal outer retinal layers and parafoveal damage, whereas the central retina may still be spared for some time. So this has been described as a flying saucer sign, where the photoreceptor damage happens in the parafoveal region and the foveal area is spared. So when you get an OCT done for these patients, look for signs of RP damage, look for photoreceptor damage, and that will help you in identifying these cases of hydroxychloroquine toxicity. So what are the major risk factors for these cases? SCQ in a dose of more than 5 milligram per kg real weight, or a chloroquine in a use of more than 2.3 milligram per kg kilo weight. Duration of use more than 5 years. Any patient who has got a renal disease, because these drugs get excreted through the kidneys. So any patient with a subnormal GFR, any patient with a concomitant drugs like tamoxifen, or any underlying macular disorder, because that will first of all avoid or prevent you from doing a proper screening. And patients with an underlying macular disease themselves are susceptible to SCQ and chloroquine toxicity. So when you come across these patients, it's important to have these screening tests, which are either an automated visual field. And one more point to remember is that for Indian and Asian population, the visual fields happen more in the parafoveal area rather than the central visual field. So it's not just important to get a 10-2, but also a 24-2 or 30-2 field also needs to be done for your patients. Apart from that, in OCT, like what I've already shown, so these are the primary tests. Apart from that, you can do a multifocal ERG or autofluorescence. But the two main tests which help us are either number one, the visual field, and number two, the OCT. Unlike or contrary to popular belief, color testing, Amsler field, full field ERG, time domain OCT, and fundus examination are not recommended for screening. For screening, you need to do visual fields and a spectral domain OCT. Phenothiazines again are known to induce toxicity if you use them for a long stage, and you can come across patients with this diffuse RP damage. So if you see a diffuse RP damage, again, a point, if it is not fitting into any of your clinical spectrum, is to take a good history and see what are the drugs the patient is taking. In fact, that is something which I have said this multiple number of times, but I'll still repeat. Whenever you see a patient whose clinical presentation is not fitting into any of your classic clinical findings, or it's not merging into your diagnosis, it helps in going back and taking a history of what all are the drugs which the patient is on. So coming to few more drugs which are known to cause retinal toxicity, MEK inhibitors and immune checkpoint inhibitors. Now these are commonly used chemotherapeutic agents now against metastatic cancers. Trametinib, selumetinib and cofimitinib are common MEK inhibitors, and nivolumab, pembrolizumab and ipilimumab are now used checkpoint inhibitors for diseases in metastasis and also renal cell carcinoma, small cell carcinomas. So let me show you this one was patient. This was a patient who presented to us with these multiple neurosensory detachments. And in OCT through the lesions showed this multiple neurosensory detachment. This absolutely classically looked like what a VKH or a Vogt-Koyanagi-Harada disease would look like. And we would have started this patient on IV methylprednisolone and long-term immunosuppression. But when we took the patient history, this was a patient who was a known case of small cell carcinoma and was taking an immune checkpoint inhibitor. So this was basically a VKH-like presentation secondary to imoprimumab. And we stopped the drug, consulted their oncologist, started this patient on systemic steroids, and most of these lesions regress. So it's important then to talk to the primary caregiver, whatever who is the physician, either an oncologist or the primary physician, have a discussion with them, take them on board, inform them that this is a drug toxicity which you are facing, and you may probably need to discontinue the offending agent and start on an alternate treatment for these patients. Apart from that, you can also have some drugs which cause an occlusive retinopathy. Interferon alpha 2A is known to sometimes cause an occlusive retinopathy. So is something which was very commonly reported for some time, hemorrhagic occlusive retinal vasculitis, which was seen with patients who were given intracameral vancomycin post-cataract surgery. And we had started seeing a few of these cases, though these cases were more commonly reported in US in 2016-17. But even we saw incidentally 2 or 3 patients who were given intracameral vancomycin and came up with an extensive occlusive retinopathy. Interferon is known to sometimes cause a microangiopathy. So if you see a patient with these multiple cotton wool spots, dot hemorrhages, signs of an angiopathy, again, take a history of the drugs which they are taking. And like I said, occlusive vasculopathy subsequent to a cataract surgery, if the patient has been administered intracameral vancomycin, then that clinches your diagnosis that you are dealing with a vancomycin-induced hemorrhagic occlusive retinal vasculopathy. So let me show you one more of our cases. This was a patient who came to our clinics. This had a patient who had developed endophthalmitis, was treated elsewhere, had undergone a vitrectomy and intravitreal amikacin. So you see these areas of ischemia, this whitening over here, which is more clearly appreciated on a red free. And when we did an FFA, we found this entire area of macular ischemia. So this was one patient who had developed macular ischemia subsequent to administration of intravitreal amikacin. So when patients come to you with macular ischemia, again, a prudent idea to investigate the drugs which the patient is taking. Sometimes again, you may see patient who has got a feature of a personal-like retinopathy, where you see these hemorrhages, areas of retinal whitening, features probably resembling a CRO, multiple hemorrhages again in all fields. And this was a lady who was taking gemcitabine for her CA breast. So gemcitabine, a drug which is now being used by oncologists for CA breast, CA ovary, and small cell carcinoma, is occasionally known to cause features similar to a personal retinopathy. Now, this is one more patient, which again shows how important drug history becomes in our clinical practice. This was a diabetic patient who had a macular edema in both the eyes and had been advised for Ozurdex in both eyes. In fact, the patient did receive 2 injections of Ozurdex in both the eyes. But even after 2 injections of Ozurdex, there was not a significant regression of macular edema. And then when we went back and asked the patient what are the drugs the patient is taking, this patient was taking pioglitazone. Now, pioglitazone is known to cause macular edema sometimes in some of its patients who are being administered this drug. So we discontinued the patient on pioglitazone. The patient was given 1 more Ozurdex, but subsequently most of the macular edema regressed. Now, this macular edema did not regress after 2 injections of Ozurdex, but after we stopped pioglitazone, we started seeing an improvement in this patient. So again, when your patients come to you, it's important to take a history of what are the drugs they are taking, specifically in cases of recalcitrant macular edema. So what are the drugs which are known to cause macular edema? Paclitaxel and docetaxel, again, drugs which are used for chemotherapy in breast cancer, are known to cause paclitaxel-induced maculopathy and macular edema. Nicotinic acid, a cholesterol-lowering agent, is known to cause macular edema. Pioglitazones, like what I've already said. Then a drug called fingolimod, which is used for multiple sclerosis. And one more commonly used agent is niacin or vitamin B3, which is these days a component of lot of dietary supplements. So patients who are taking vitamin B3 or niacin supplements also can sometimes develop a recalcitrant macular edema. So the point I'm making is that in patients whose clinical features are not responding to your treatment, in recalcitrant cases, it again becomes important to revisit the drug history. So like I said, there are reports of rosiglitazone, pioglitazone leading to macular edema. So it's important for us as clinicians to be aware of these effects. Apart from that, there are certain drugs which are known to cause a crystalline retinopathy. Tamoxifen, canthaxines, telcambola, and nitrofurantoin are known to cause something like this. So if you see a patient with this sort of multiple deposits in the retina and photoreceptor loss and central disruption of ellipsoid zone, this is a case of a crystalline retinopathy. And this patient was actually a case of crystalline retinopathy subsequent to tamoxifen. Now, apart from drugs, it's also important to know the reason for knowing the drugs is that sometimes you can see some indirect manifestations of drug use. So if you see a patient with multiple white-centered hemorrhages, these are patients who may have a blood dyscrasia, number one. Number two, they may have developed anemia subsequent to or secondary to myelosuppression, which can happen after any of the drugs which we are taking. So any patient who presents with features of white-centered hemorrhages, anemic retinopathy, it again becomes important for us to go back and take a history of the drugs which we are taking, drugs like chloramphenicol, methotrexate, Bactrim DS, all the cytotoxic agents, and even valganciclovir, which we give for CMV retinitis, is known to cause sudden myelosuppression. So we have had patients of CMV retinitis who were given valganciclovir and they came back with blood counts going as low to 2,000, 3,000. These are patients where you need to stop these drugs and probably take a consultation from a hematologist. They may even need colony stimulating factor infusions to take care of the anemia or the myelosuppression which happens. So again, when you see a picture like this, go back and take a history of what are the offending agents the patient might be taking. And what you may know is, surprisingly, that anemia or the picture like this may be subsequent to the myelosuppression which has happened because of any of the drugs which has been given to the patient. Again, while this patient's picture looks classically like a CMV retinitis, this was a patient who was not a seropositive patient. This was a patient who was a known case of vaginous granulomatosis and was taking rituximab, number one, along with mycophenolate mofetil and methotrexate for the systemic vasculitis of methotrexate. And subsequent to the immunosuppression which this patient developed, he developed a CMV retinitis. So when you see features of viral retinitis or a CMV retinitis in a patient who is not seropositive, again, it's important for us to go back and take the history of the drugs which the patient is taking, because these patients may be on long-term immunosuppression, they may have an underlying blood dyscrasia, or may be taking chemotherapy, all of which may predispose your patient to developing these features which are suggestive of a CMV retinitis. Now, apart from that, one more point which I probably failed to mention, which I have not actually covered, is features of optic neuritis or optic atrophy. Again, there are drugs, including drugs for HIV and including drugs which may lead to optic neuritis. So if you see a patient who has developed features of optic neuritis suddenly, patients who have been on cytotoxic drugs, again, that may be secondary to the drugs which they are taking. Benign intracranial hypertension is known to occur subsequent to a lot of drugs. So that is why the point which I'm driving home again and again is that when you see these cases, when you see cases which are a diagnostic conundrum, the only way forward is a meticulous history, a good meticulous history, and repeat a good meticulous history. And this is the take home point which I want all of you to take back. When in doubt, when you have cases which are not responding to treatment, recalcitrant cases, please step back, revisit the history, check all the drugs which patient is taking, and for all that you may know, the features which you are seeing may be subsequent to any of the drugs which the patient is taking. Thank you so much.
Thank you so much, sir. Thank you for the wonderful lecture, and you've explained it so very well with the case scenarios. I think that's very easy for the postgraduates to follow with the help of the case scenarios. So there are a few questions that are there on social portals. We'll take them one by one, sir.
Sure.
Yes, sir. So first question is that what would be the hydrochloroquine follow-up schedule? What would you recommend?
So if a patient has been taking SCQ for more than 5 years, we usually do end up seeing them every year. We ask them to come for a screening now after every 1 year after they have been started on SCQ. All patients of SCQ and chloroquine ideally should get a baseline checkup done. That is number one. Subsequent to that, if they are taking less than 250 milligrams per day of hydroxychloroquine, or if it is less than 2 to 3 years, you don't need to ask them to come every year, unless and until they have got a concurrent renal disease. In the absence of that, you need to start screening them after 5 years, and you need to then screen them every year.
Okay, sir. And how often would you do each investigation, sir? Like if we talk about OCT or
So for
HFA?
all the patients who come, we do get a HVF as well as OCD done at every visit.
Okay, at every visit.
Yeah.
So and that comparative. And so how frequent would be the follow-up?
Every year, like I said,
Every
once
year.
a year.
All right. Okay, sir.
If there are signs of SCQ toxicity, then anyways you have to stop. So you stop, you call their rheumatologist, inform them that the patient has got signs of early SCQ toxicity, and you need to discontinue that medicine. If the patient does not have signs of SCQ toxicity, you still need to see them once a year.
Okay, sir. So just a follow-up question here, that in case we are deciding to stop the drug, so after stopping the drug, how much time does it take for the retina to settle down? Like
So,
to the
so
symptoms
these are irreversible changes. Once those changes have set in, they will not go away. That's why it is important to prevent it. And that's where the concept of screening lies. You want to prevent the maculopathy from developing. Once it has developed, you can't reverse it. You may still be able to stop it at that stage, but it will not go back. The earlier you detect it, the better the visual prognosis, because that the lesser the damage has occurred. But once the photoreceptor damage has occurred, that is irreversible.
Right. So it is important for all the physicians also to follow up on the HCQ patients regularly.
Yeah.
Okay, sir. So the next question is that which important drugs to remember the side effects of, because of course, like as a physician while treating or as an ophthalmologist, we can't remember all the drugs, but which drugs should be strikingly remembered?
All right. So few of the common drugs which we have to remember are like one which I showed, topiramate, chlorothiazide. So these are, so whenever you see a patient who develops a sudden angle closure and sudden peripheral ciliary detachment and a hypopia on uveitis or an anterior uveitis. So I've already shown some drugs like topiramate, chlorothiazide, hydrochlorothiazide. So these are the drugs which you have to remember, number one. Number two, the commonly used drugs are HCQ, which anyways we have discussed. Yes. Pioglitazone, because that is very commonly used for treatment of diabetes, and any cytotoxic drug. Now it's important to know, and the point is that you should have the index of suspicion. Obviously, nobody can remember 500 to 600 drugs and their rare adverse effects. First of all, these are not very common. These are uncommon adverse effects, because otherwise, if they were common, we would not have been using these drugs in the first place. So most of the adverse drug effects are usually uncommon, relatively rare. And that is why the only point which I want to stress is have an index of suspicion. Keep that at the back of your mind as one of the possible differentials, so that it doesn't slip out of your radar altogether. So when you see patient with uncommon atypical presentations, get a checkup done. Like the patient of VKH which we had shown. Now this was a classic VKH. Otherwise, at any of day, if you show me this image and you show me the OCT, my first diagnosis will be this is VKH. Possibly sympathetic ophthalmia, posterior scleritis, because they are again similar. But your first diagnosis is VKH. But again, that's why I said it is important for every patient that to take a drug history. And if you find in the drug history a patient's drug which can be possibly incriminating, then you need to then elaborate, go back, check that still further. So when we took this patient history, we came to know that this was a patient of small cell carcinoma taking iprotelinib. And that's when we stopped the drug, and that's how the patient responded. So obviously, nobody can remember all the rare adverse effects. It's impossible to remember. The point to remember is to take a drug history in every case. That should be a part of clinical examination of every single patient whom we see. As a rule, we should ask for a drug history. What are the drugs the patient is taking? Does the patient have any history of allergy to any other medicine? Simple enough. 2 points.
Okay, sir. So, like about ethambutol toxicity, there is a question. So for ethambutol, it says that in the early stage, if it is diagnosed, it is reversible. Do you think that would be true?
All right. So first of all, let me just speak a little bit more about ethambutol. I did not cover it much because it does not cause a retinal manifestation, causes more of optic nerve damage, but still true. The point is that now we are seeing more and more of ethambutol toxicity. And the reason for that is that the government of India changed the RNTCP program in 2017. And with that, they came up with fixed dose combinations of ethambutol. Plus ethambutol, which was earlier taken for only 2 months, now is being taken for 6 months instead of 2 months. So that means our patients are taking ethambutol for 6 months. And the existing literature basically says that if anybody is taking ethambutol for more than 2 months, then a safe dose is less than 15 milligram per kg per day. Now, because of the fact that our patients are taking fixed dose combinations, that means anybody who's got a weight of 20 kgs, as well as somebody who's got a weight of 40 kgs, both of them will be taking the same dose of ethambutol, which is 550 milligram every single day. So that means anybody who is a 20 kg person will be taking around 375, 37.5 as compared to somebody who's 40 who may be just taking around 15. And that is why we are now seeing a kind of an increased influx of ethambutol toxicity in our patients. So any patient, and again now there is jury still out on the fact that whether ethambutol induced optic changes are reversible or irreversible. There are some people who say that they are early stages, they are reversible, but what we are finding in our patients is that they don't get reversed. You may hardly see a one-line improvement in vision. So again, any patient who is on ethambutol, number one, they also need to get their kidney or renal functions tested, because the main mode of excretion of ethambutol is through the kidneys. So renal mode of excretion is what happens for ethambutol. So anybody who's got an impaired RFT again needs to take this drug with caution. And usually you will see optic changes. So the patient may come to you with a decreased vision, field losses, and a red-green color defect. But the changes, whether they are reversible or irreversible, is something which I would probably not be willing to comment that they are reversible, because a lot of times they are actually irreversible.
Right, sir. I agree, sir. Probably one or two letters of a line, they would not be considered as reversible.
Exactly.
Just like probably controlling it before it deteriorates further.
Exactly. And we are trying to now bring this into advocacy to ensure that Government of India understands that the fact that the new guidelines are actually creating a lot of damage.
That's true.
Yeah.
That's true, sir. So there's a question by Dr. Soni that she would like you to elaborate a little bit about BH crystalline retinopathy.
So BH crystalline dystrophy, again, you will see these multiple crystals, which like what you see in a tamoxifen induced maculopathy, where you will see these multiple crystalline changes. You will see these multiple shiny refractile dots. The same sort of appearance may also happen in talc retinopathy. And talc retinopathy is common in drug abusers. But BH crystalline retinopathy, again, you will see these multiple shiny refractile dots. And again, then it becomes important when we see this picture to ask our patient for history of any drug use.
Yes, sir. Okay, sir. So she has another question about canthaxanthin toxicity, and how does it present, and what happens in canthaxanthin toxicity?
So I think I have an image of canthaxanthin toxicity also here. If I can just probably show that. No, all right, canthaxanthin. I did not include that image over here. But yeah, again, canthaxanthin will again present with the same thing. It is basically a carotenoid which was earlier used in some of the dermatological conditions. And it also then presents with multiple crystalline dots. Again, these are crystalline retinopathy examples. So patients who present with crystalline retinopathies, it becomes important for us to take a history of these drugs.
Right, sir. That is true. So there is one more question, sir. When we are giving intravitreal drugs, so how do you think that the chemotherapy drugs that are given intravitreally will cause any type of retinal toxicity, and how many injections might lead to a retinal toxicity?
All right. So most of the chemotherapeutic agents which we use, it's not a dose dependent toxicity. It's more of an anaphylactic or an adverse event. Now, as far as how many intravitreal chemotherapy, does it cause any RP toxicity? I think the best person to answer that will be Sir himself, because I think nobody has got as much experience as when it comes to intravitreal chemotherapy than Sir would have. So maybe I'll ask him to take that question, because I have honestly not come across cases of retinal toxicity subsequent to intravitreal chemotherapy.
I think he got logged out, but I can probably answer on behalf of him that till now, like we have seen that we do not see the chemotherapeutic drugs causing retinopathy as such. And we also limit ourselves. We do not go beyond, say, if you're talking about intravitreal topotecan. So we very carefully go about it. And probably after 9 injections, 8 to 9 injections, we switch to adding melphalan along. So because if the vitrocedes are not regressing, so we go ahead and add another
most of the chemotherapeutic agents have been shown to be not toxic to the RP or to the photoreceptors.
Yeah, because the absorption is, it's a superficial absorption. So it's not really affecting them systemically. And that's the whole point of giving it intravitreally. So similar question has been asked about amphotericin, like, for all the vegetative matter injury, do you recommend giving amphotericin B, and will it cause any retinal damage?
So amphotericin usually will be maculotoxic if you give it in an increased dose and a lot of times. But the point to remember also is, and that is where a lot of people get confused, amphotericin is known to cause an inflammation even otherwise. So there will be times for a patient you may have given an amphotericin B, the next day patient may come with a bit of a hypopion and you may think that there's a worsening, but it's not a worsening, it's just a vitritis and an inflammation which has occurred secondary to amphotericin B. The other point to remember for all the antibiotics or for all the agents is that they've got their own respective half-lives based on the pharmacokinetics. So the half-life of amphotericin B is around 72 hours. So if you intervene earlier than that, then obviously you are predisposing the eye to a macular toxicity. But if you respect the half-life, don't intervene at one day earlier, then obviously you are reducing the incidence of a macular toxicity. So you have to administer every single drug in a way which is holistic and which is amenable to the pharmacokinetic profile of that patient, of the drug.
That is true. That is true, sir. So another question that you have mentioned about the role of ERG. One of the postgraduates would like you to, elaborate on the role of ERG and what would you do to observe the same?
ERG in which cases?
So in drug toxicity, would you like to do a follow-up ERG?
So that's what I say. So ERG is one of the optional tests which we have, and that also is not a full-field ERG. It's a multifocal ERG, which gives you the area of damage at the macular area. Hydroxychloroquine is known to affect the macular area. It's not a generalized loss. And even for generalized photoreceptor damage, a much more easier investigation to do is an autofluorescence. So we don't usually rely that much on ERG. We rely more on an autofluorescence.
Okay, sir. So nanoparticles, there's a question on that. Like nanoparticles are promising drug delivery agents. Most commonly, it would be silica or titanium oxide. So do you think, what is your comment on nanoparticles being used and will they be affecting the retina?
Too early to comment upon that. For any drug which will come into picture, including nanoparticles, there has to be initial animal model studies where we will have to see and evaluate whether it's causing any RP toxicity or photoreceptor damage, and only then will it come for use in human eyes.
Okay, sir. So another question is by Dr. Soni that
pentosan,
pentosan macular toxicity used in hemorrhagic cystitis. What would be the changes?
All right. Now the thing that has to be kept in mind for pentosan is, first of all, pentosan is known to cause macular change, but that is also not very common. It's rare. It's not something which is as commonly seen as what people believe. And pentosan is known to cause a macular degeneration. So again, what you will see in these cases is RPE damage. So you will see something similar to, if I can just show you an image, wait. Is my screen visible?
Yes, sir.
Give me a second. All right, let me show you this image over here. So what you see is an autofluorescence image over here. But what happens in pentosan is you see a widespread damage at the level of the photoreceptor. So it's like a central area of damage which has happened. It looks a bit like a macular degeneration. There are times when people may confuse it with a macular degeneration. You will see extensive RP damage. You will see a photoreceptor damage. And you will see this entire area of stippled hyperautofluorescence as well as a photoreceptor damage on OCT. And people have confused it with a geographic atrophy with the macular degeneration. And that is where, again, if it is like I said, if it is not fitting into your diagnosis, that's when it becomes important for us to revisit a history. Though I have never ever seen a case of pentosan induced macular degeneration, but I have come across cases which have been anecdotally reported. Personally, I have never seen one.
Okay, sir. So like, since this is like a postgraduate talk, and sometimes postgraduates really need to know about what are the most common questions and what the examiners expect them to know in your particular topic. So do you have any inputs for them, sir?
All right. Now for postgraduates, not only for the matter of exam, but even for the matter of dealing with your patients. It's like I said, it's important to take a good history. And why does a drug history become important? This is something which I actually keep on telling all my residents and fellows. Get into the habit of just taking 1 minute and asking your patient what are the drugs the patient is taking. That will really help you. If your patient gives a history, we have had 2 patients or maybe even 3 who have given a history of allergy to penicillin. One of them was a patient of syphilis. Now, if we had given that patient penicillin again, that could have been possibly catastrophic. So we ended up giving the patient doxycycline. So it's important for us to ask the patient what are the drugs they are taking, number 1. Number 2, is there a history of any past allergy or anaphylaxis to any of the agent ever? And obviously, patient will not understand what is anaphylaxis. So what we have to ask is, does the patient have history of any breathlessness, any dyspnea, any skin eruptions, any discomfort after taking any medicine? And the patient will then volunteer, I had taken this medicine earlier and I developed skin rashes or something. So that is one thing which you need to remember, number 1. And as I think, as far as exams are concerned, I think most of the only common exam question usually is the hydroxychloroquine or chloroquine toxicity. That is one of the most common exam questions. And for that, there are multiple papers also available. There is an American Academy guideline, which has come in 2016, which is easily available about what are the screening tests. I had already shown that what are the tests to be done. So what you need to remember is the dosage of hydroxychloroquine above which it is known to cause toxicity. What are the signs of hydroxychloroquine toxicity? When to do screening? What to do for screening? And that's it. As far as postgraduates are concerned. But I think as postgraduates, we are now doctors.
And sir, also,
yeah, sorry. Go ahead.
No, sir. Go ahead, sir. Please.
So that's what I think, that as postgraduates, it's important for us to understand that now we are responsible for taking care of our patients. We are not in MBBS. We are now postgraduate doctors. We are now residents in our own respective departments. And the onus or the responsibility of taking patients lies upon us. And that is why all of this needs to be inculcated in our clinical practice.
So there is a question on oral contraceptives, which are common in gynae practice and retinal toxicity. What do they have to be careful about, and does it make any major change in the
two things. Oral contraceptives are sometimes known to cause a hyperestrogenic state, which again may predispose to thromboembolia and lead to a vasculitis. Number 1. Number 2, the second most common cause of CRAO among young females is a history of OCP. So if you come across a patient who has developed a CRAO, a young patient, obviously if it's a 65, 70-year-old patient, you will not give cognizance to that history. But for a 30, 35-year-old lady to come up with a CRAO, that's unusual. And there you need to go back and take a history of what are the medicines the patient is taking. So one of the most common causes of CRAO in young healthy females is a history of using OCP. So somebody has asked, CME, is it reversible? Yes, this one is reversible.
Yeah.
Yeah, so
no, sir, the question,
CME by dietary supplements, CME by pioglitazone, all of those are reversible.
Okay, sir. So the next question would be that in HCQ toxicity, which is the earliest sign, and how reliable is autofluorescence for the same?
So autofluorescence is reliable. You can start seeing these autofluorescence changes. You can see this hyperautofluorescence, but more than autofluorescence in an OCT. And that is why I've been saying the 2 primary tests are visual fields and OCT.
Right, sir. So another question is what is the diagnostic criteria of HCQ toxicity? Is it just based on HFA and vision alone, or is it based on structural changes and OCT or OCT?
It is based on structural changes, and that is why OCT is important. That is, see, the concept behind screening is to detect a disease before it manifests. So you will see early photoreceptor damage, but the patient will still have a vision of 20/20. And that is why I'm saying you have to get an OCT and an HVF done, because then you will see some field effects in your HVF. You may see photoreceptor damage on OCT, even though your patient vision is 20/20. And that is the sign or stage where you should discontinue HCQ.
Okay, sir. So HVF, you would prefer a 10-2 or a 30-2?
24-2.
24-2. So a 24-2 will be useful for follow-up.
Yeah. Even for the first visit.
Okay, sir. And what if, sir, MFERG is not available?
Doesn't matter. Like I said, the primary 2 tests which need to be done are HVF and OCT. If an multifocal ERG is available, good enough. If it is not available, it's an optional test.
Right, sir.
See, this is what I am talking about. If you can see this slide. Primary tests are automated visual field and SDOCT. objective tests as needed, or if available are multifocal ERG or autofluorescence. So what you should do is an visual field and an OCT. If you have an access to multifocal ERG and autofluorescence, good enough. Even if you don't have them, at least a standard domain, spectral domain OCT and an HPF.
Okay, so I think the postgraduates should take a screenshot of the same because it's quite important. And I think this can be put together in a tabular form, and it would be good for your answer to be there. And these screening tests are pretty important, and they come even as a heading of screening tests, you can add for drug toxicity as a central point.
Yeah.
Sir, one more thing is that do you think that in an evaluation, a baseline evaluation of color vision in all these patients who are taking up medications for a long time, will that be helpful, or that's not really a very reliable?
It's not very reliable. You should get it done if you can. Sometimes it may give you a clue, like for ethambutol toxicity, obviously a red-green color vision defect will be important, but they are not absolutely reliable.
Right, sir. And so I know that you mentioned Amsler grid as a technique over here, but I do remember from my PG days that there was a lot of confusion about how Amsler grid testing is done. I think that would be a nice add-on.
So first of all, if you read the line, it is not recommended for screening.
Right, sir.
Yeah. So a lot of times people end up using Amsler grid. It's not recommended for screening. Amsler grid is basically a home screening tool for you to detect macular changes. And important thing is for residents to understand, it's first of all done uniocularly. So close one eye, there is a central area upon which you're supposed to focus, and then see if you are seeing any scotomas or any metamorphopsia. So Amsler's grid is helpful for monitoring of scotomas and metamorphopsias, but it is not recommended for screening of SCQ toxicity.
Okay, sir. So what if any patient has a persistent or ongoing retinal pathology, like say diabetic retinopathy or hypertensive retinopathy, then in them, how often would you recommend a follow-up besides their follow-up of hypertension and diabetes?
So if a patient has got an underlying diabetic disease and on top of that they develop early signs of SCQ, then we will recommend them to stop SCQ. The reason is because in them, the underlying diabetes or hypertensive retinopathy will in itself confound the disease. So what you may be seeing, the diabetic manifestation will confound the presentation of SCQ toxicity. And that is why for patients with an underlying macular disorder, it is important for us to then discontinue SCQ, not because of the fact that it will have an interplay, but also because of the fact that now your diagnosis becomes confounded.
Okay, sir. I think it would be a very interesting thing if we can actually, like how we send the patients to the physician for like a clearance for say chemotherapy or clearance for surgery. I think that should be a practice that the physician send for the clearance of starting certain
toxic drugs. It is actually a practice. We do get a lot of patients from NIMS who are started on SCQ and they come for a baseline screening. Even if they don't get a baseline screening done, a lot of times, at least after 3 to 4 years, they do send the patient to us for at least one checkup.
Okay, sir. And then there should be like a valid certification here that yes, now you can initiate or keep a regular follow-up at a particular interval as decided by the ophthalmologist.
Yeah.
Postgraduates should keep that in mind because you'll be practicing in multidisciplinary hospitals where you should have such an interaction.
Yeah.
And if a patient has a macular pathology already, like a macular star, then in such cases, not just a retinal pathology per se, but in macular pathologies, would you give such a clearance?
No, that's what I'm saying. If you have got an underlying macular disease, then you have to discontinue SCQ. Because how will you follow them up? How will you know that the damage that the patient's retina is now having is because of SCQ or because of the disease? You can't. That disease will confound or confuse you. And that is why for patient with an underlying macular pathology, you need to discontinue SCQ.
Okay, sir. And in patients who have persistent retinitis pigmentosa, it's okay to go ahead and give the toxicity clearance?
No. Retinitis pigmentosa, already you got a photoreceptor damage. The same thing.
Okay. And so not even in the
important to understand, we are not talking of something like NPDR, which is not affecting the macula. We are not talking of any single macular retinal disease. We are talking only of macular pathologies. Any patient who has got an active macular pathology, in those cases, it will be nearly impossible to monitor the effect of SCQ. And that is why we recommend that they should be stopped. Obviously, this has to be in conjunction with the rheumatologist. If the rheumatologist feels that no, for some reason they have to continue, then you have got no other option but to take the bitter pill and continue.
Right. So like in cases where we know that the treatment is mandatory and we have to then just keep the patient on regular follow-up and go ahead with the drug.
Yeah.
Right, sir. And any role of OCT angio in these patients, sir?
No. We have not actually explored the role of OCT angio in these patients, but OCT angio again basically shows ischemic changes over there which may happen. There are some reports which have now started saying that there may be some capillary or void areas which can be seen, but these are unvalidated occasional anecdotal reports. So at this point of time, no significant role in screening. Maybe in future, you never know.
Okay, sir. So what is more toxic, chloroquine or hydroxychloroquine?
Chloroquine is more toxic. That is why hydroxychloroquine came in place in the first place. If you look at it, most of the drugs which go on to develop usually are the ones because the previous one was a bit more toxic. And that is why, while for chloroquine, if you look at it, for the cumulative dose of chloroquine is much lesser than that of a hydroxychloroquine.
True, sir.
So if you look at this over here, anybody who's taking more than 5 milligram per kg of hydroxychloroquine, whereas the dose for chloroquine is 2.3 milligram per kg. And the reason is because chloroquine is supposed to be more toxic than hydroxychloroquine.
That's right. I think please, postgraduates, again, take a screenshot of this because it's quite important and you should take care of it. Like this, if you write this as a part of your answer and you memorize it, it's kind of useful. And so what are the common drugs which can cause a combination of a uveitic component and a retinitis component?
The same, the cytotoxic agents like MEK or checkpoint inhibitors are the ones which can cause a uveitis as well as retinal component. Topiramate, hydrochlorothiazide, rifabutin are known to cause anterior uveitis predominantly.
Okay, sir. And thanks a lot, sir, for covering all the questions so efficiently and quickly. And it's a very important topic for all of us, not just postgraduates, as physicians, as clinicians, and even as general ophthalmologists and experts in their respective fields, because so many times we come across retinopathy in different forms and we tend to ignore it, or we tend to miss these key points and key features which it presents with. And it's very important for us to grasp all of them. And postgraduates must remember them because you might not see them in your practice while you're in your MS or DOMS or even DNB. But later on, you need to grasp these minor points for a better outcome. Is that right, sir? Any of the postgraduates who are online here, would you like to ask any question? Okay, sir, I think you have clarified more than the questions that they wanted to even ask because you've covered everything in very, in a detailed manner. Thanks a lot, sir, for taking out your time.
No, not at all. It's a pleasure to be with all of you. Take care.
I'm sure that you have taken out your time from your busy schedule. And the next class will be on the 1st of April. That will be the International Masterclass on Radiation Retinopathy by Dr. Paul Finger. So from the drug toxicity component, we will be moving on to the radiation retinopathy component. So we'll all see you there. Thank you again, sir, for being there.
Have a great day, everyone. Yeah, bye.
You too, sir.